My name is Dr. Shahal Rosenblatt. I'm a lifespan neuropsychologist evaluating and treating children and adults who are contending with various neurological and psychological obstacles that stand in the way of more effective functioning. The subject of the current episode is autism spectrum disorders, or ASD, including the diagnostic features, brain regions involved, and treatment recommendations. I'm more than happy to answer any questions. You can email me or post them to the YouTube site. First, some statistics on autism spectrum disorders. So according to the CDC 2016 survey, ASD is reported to occur in approximately 1 in 58 children aged 8 years. Boys are 4.3 times as likely to be diagnosed with the disorder as girls, and this can be for a number of reasons. One is that there are obvious genetic differences between boys and girls, and this may account for a portion of it. There is also the possibility that the diagnostic criteria that we use are biased towards boys, where behavioral criteria play a more important role and boys are more likely to exhibit those criteria. In addition, there's a phenomenon known as masking, where girls present as more socially adept, even though their disorder is quite severe, and this makes them fall through the cracks. But that's a topic that we will discuss at another point. Prevalence rates are relatively equal between non-Hispanic whites, non-Hispanic blacks, and Asian Pacific Islanders. On the other hand, the rates for Hispanics are somewhat lower than for these other groups, and it is not quite clear why that is the case. Of those individuals with available data, 33% had IQ scores that are at or below 70, showing that there's a high frequency of intellectual disability. Interestingly, 39% of girls and 32% of boys showed this type of pattern. And again, it is not clear why more girls are diagnosed with intellectual disability, but again, it may be that they need to present with more severe symptoms in order to be evaluated and ultimately diagnosed. Now, there is clear bias when it comes to people of color, with 47% of Black children and 42% of Hispanic children presenting with lower IQ scores. In addition, Black and Hispanic children are less likely to have been evaluated before 36 months and are typically diagnosed later than their white counterparts. And so this is something that we need to keep in mind, and it affects the types of services, when services occur, and obviously how much progress can be made, because there are critical periods during which our ability to make changes is more effective. So what I'd like to do now is present the case of Jack. He's a 4-month child that I evaluated. All identifying information has been changed. So he was referred for a neuropsychological evaluation due to concerns with behavior, cognitive abilities, and social development. He wasn't taking any medication at the time of this evaluation. Both parents were quite intelligent and well educated. Dad was an engineer. Mom was a molecular pathologist. So Mom was diagnosed with maternal hypothyroidism during her pregnancy and medicated with Synthroid. In addition, there was only one umbilical artery present, but it is not clear if there were any complications as a result of this. Jack was born at full term. It was a vaginal birth that required the use of forceps. Neither of them was in distress, and he was of average weight. In addition, Jack attained all his milestones, including speech and motor skills, within the expected time frame. Jack's medical history is generally unremarkable. Hearing and vision were tested within the past year or so prior to this evaluation and were within the normal range. He did develop croup when he was 15 months old, and this required an overnight hospital stay. He does not present with allergies or complaints of pain. At the present time, Jack lags behind peers in activities of daily living. Moreover, he's picky with what he eats, generally limited to 4 different types of food that he prefers. He can be oppositional and presents with behaviors that lead to tantrums. He has a high activity level and is generally described as an energetic boy. He completed his preschool year at a local school where he was receiving remediation services, and this included a special education itinerant teacher who was with him 90 minutes per day. Speaking to the teachers, they reported that he will not eat in school. He also struggled with attention, which was very limited and often prevented him from completing tasks. Socialization was another concern reported by both the parents and the teachers, with little peer interaction occurring except with a specific peer who was also a very quiet child and who was able to be very patient with Jack. Academics were reported to be far ahead of the typical child his age. He was a fluent reader with pretty good comprehension for what he read and was able to also complete math problems that were beyond that of many children older than he is. Attention was a major concern at home and in school. Jack had a hard time staying on task, except obviously when involved in things that he enjoyed. And this included building with Lego blocks and other games, but it was also difficult to shift him away from such activities. He proved to be impatient and needed to be kept busy. His parents described him as more active than most of his peers. He likes to talk and talks a lot and often says things without filtering them. Obviously, he's a young child, but we're talking relative to his age. His parents said that he is able to stay on topic, but it's also difficult to get him off of a specific topic. At 2 years old, Jack was evaluated through early intervention and classified as autistic. Approximately 6 months later, he was reevaluated at a local medical center and was found not to meet diagnostic criteria for an autism spectrum disorder. And here we see some of the issues that come up with diagnosing children. Depending on who's doing it and what instrument they're using, you can get different results. And it is quite important to make sure that you use someone who is well versed in working with children who are on the spectrum. He was reevaluated in 2017 by the Committee for Preschool Education, and you can see the results of intelligence testing for the Stanford Binet 5th edition. Overall IQ is in the low average range, as are nonverbal and verbal IQ scores. Quantitative reasoning was stronger. His adaptive skills were quite low. So at this point, I'd like to go over what the diagnostic criteria are for autism spectrum disorder. And this comes from the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So here we have the diagnostic criteria for autism spectrum disorder as written in the DSM. So first one, persistent deficits in social communication and social interaction across multiple contexts. These deficits include weaknesses in emotional reciprocity, which means the typical give and take that's involved in interactions, back and forth involved in conversations, being able to share interests, emotions, experiences. Number two, deficits in nonverbal communication and behaviors used for social communication. And so when we look at most speakers, there's some type of hand gesture. You see a lot of politicians doing this thing with their thumbs, um, making eye contact, attending to body language, including personal space. There is also number three, deficits in developing and maintaining and understanding relationships. So adjusting behaviors to suit different contexts and depending on who you're interacting with, how you interact with them. And so there's a difference between interacting with a coworker versus a close friend versus a partner versus a parent. And so children on the spectrum often miss a lot of the cues necessary in such situations. Towards the bottom of the slide, you see criterion C. The symptoms need to be present early in development, but may not necessarily become fully manifest until social demands exceed limited capacities. And so, as is the case with any disorder, a lot of the symptoms don't become manifest until they should appear. And so it's difficult to diagnose an infant with, social deficits because they're not expected to do certain things. So in infancy, you may see issues with smiling. And so the infant may not smile in the same way that a typical developing child does. There may be limited eye contact, but you don't have to because you can't have a conversation, you can't look at the give and take of conversations. Because play is limited, the reciprocity involved in that give and take may not be able to be determined until later in life. And the symptoms also must cause clinically significant impairment, whether in social, occupational, or other important areas. If there is no significant impairment, then you don't have a disorder. And again, we have to make sure that the disturbances that we see in behavior and interaction are not better explained by the intellectual disability. And so, for example, someone with a very low IQ may appear to be autistic, but they're really not. The reason they're presenting in the way they do is because the intellectual disability prevents the development of language, prevents the development of certain motor skills. And so it is the intellectual disability leading to the symptoms as opposed to autism spectrum disorder that makes social interaction, motor skills, or other areas problematic. So here we're looking at, what happened with the previous iteration of DSM. There were a bunch of disorders subsumed under the spectrum. These were combined into a single diagnosis, and now we are required to determine the severity level. And so level one, starting on the bottom, is someone who obviously presents with some deficits in communication, has difficulty with interactions, and may appear to have decreased social interest or ability to interact, but language is generally intact, intelligence is generally intact. They may include the inflexible behaviors, circumscribed interests, but they require very little support. Level two requires substantial support. These are more severe kids, and so deficits in verbal and nonverbal social communication are stronger, more intense, limited initiation of social interaction, behavior becomes inflexible. These children are less able to cope with change or demands of the environment. And even to these children appear to have something going on even to a casual observer. And level three these are the children who require very substantial support. So they may be nonverbal, have more severe intellectual deficits. The inflexibility and coping deficits are more severe and more intense. And behavior problems are also more intense in these children. So at this point, I'd like to turn to some of the neuroanatomic findings of children with ASD, keeping in mind that this will not be a complete review of the brain systems and the differences between children with ASD and those without. Rather, my purpose here is to provide a quick overview and to show that ASD is really a disorder of neurodevelopment, and also dispelling the long-held myth that inadequate parenting in some way is a causal factor. The focus here is going to be on specific brain regions and their involvement in the symptom presentation of children with ASD. So, in a review of the literature, Bauman and Kemper found several regions to be most affected in the brains of those with autism spectrum disorders. Here we have a picture of the limbic system, which is involved in emotions, development of memories, behavior, motivation, and sense of smell. Differences were found in a number of areas that are considered part of the limbic system. These include the amygdala, which is implicated in fight or flight reactions and connecting memories and emotions. The hippocampus and entorhinal cortex, which are involved in the formation and consolidation of memory. In each of these specific areas that I just mentioned, the size of the neurons, the brain cells, is smaller and also more densely packed. Both of these are signs of curtailed neuronal development. At a certain point, we have more neurons than we need to, and so through the process of pruning, we reduce the number of connections and cells that are unnecessary, and this allows the brain to be more efficient. This seems to occur less effectively in the brains of children with autism spectrum disorders. The cerebellum is found in the posterior regions of the brain. Its role is involved in motor, mental, and sensory functions, and it is involved in various processing skills, including making predictions, preparing for events, making computations, and aiding other parts of the brain to work more effectively. It is also believed that the cerebellum is involved in making certain processes automatic. And so these processes, for example, making sequential movements. Initially, you have to practice it, you're doing it in a very haphazard way, but eventually with practice, it becomes a smooth action. And so the cerebellum itself constitutes approximately 10% of the brain's total volume. One of the primary cerebellar findings is reduced number of Purkinje cells, and these are cells that are responsible for regulating the functioning of the cerebellum as well as its output to other brain regions. The outcome means that the brain itself becomes less efficient, including resulting in less effective cognitive, emotional, and motor functions. Now I'd like to turn to executive functioning, which refers to those brain functions that help us adapt to our environment, solve problems, and determine how we're going to respond to environmental demands. And this includes social demands. Cole and his colleagues report research findings showing that the caudate nucleus of children with ASD grows at twice the rate of non-ASD children. And here we're looking at this large purple section towards the top of that purple area. The caudate is involved in motor planning, learning, inhibitory control, and decision making. And, you know, the speed at which it grows means that it's developing abnormally, and so its functions are working abnormally. The globus pallidus is the green area that we're looking at right next to the purple section here. Um, so the globus pallidus is primarily involved in inhibitory control that tends to, interestingly enough, balance the excitatory action of the cerebellum that we discussed earlier. So these two systems need to work in concert in order to allow for smooth and controlled motor movements. Imbalances can result in tremors, jerks, and other movement problems that we often see in individuals with progressive neurological disorders. And as with the caudate, there is a proliferation of neuronal growth relative to children without ASD. The nucleus accumbens, shown here in the green region, is a brain area that's involved in reward and reinforcement of behavior. Research has implicated it as playing a major role in addictive behaviors, and this is shown both in animal studies with rats and in human studies. For our purposes, the nucleus accumbens, caudate, and globus pallidus have been implicated as the regions that are most responsible for maintaining repetitive behaviors and those rigid, repetitive thoughts that children with ASD have. So the brainstem is one of the oldest regions of the human brain. It comprises about 2.6% of the brain's total volume, making it a fairly small region. However, it plays an outsized role. And so as you can see on this current slide, the brainstem is the region that connects the cerebrum, meaning the cortex, with eventually the spinal cord and to the rest of the body. It consists of the medulla at the lower region, the pons, which is the greenish-blue region, and the midbrain, which is the green region right underneath the pink thalamus. The brainstem controls and is involved in multiple functions and includes relaying motor and sensory information so that we can control our bodies and also receive sensations from the external environment. It's involved in arousal and alertness, in breathing, blood pressure, and digestion. For our purposes, we're looking at how the brainstem is involved in the development of ASD and the symptom profile that we typically see. Keeping in mind that research on the brainstem's role in this disorder is rather preliminary in nature. So in their review of the literature, Didalco and Travers cite research showing that auditory brainstem responses, meaning that we hear a sound and the brainstem response is how the brain initially reacts to and is made aware of the fact that we picked up a sound. So an auditory brainstem response is usually milliseconds in speed of processing. The research has found that this type of response is slowed in children with ASD, and the slower the auditory brainstem response, the more severe the social deficits in these children appear to be. Keeping in mind that this is only correlational data, it doesn't mean that the slow processing is causal. It's just correlated. And so one way to look at it is that a possibility of less arousal due to um, auditory and social stimuli. And so many parents report that their children do not respond to their name being called, or they hear sounds going on around them but don't necessarily respond to them, or at times may actually respond too much to certain sounds. So the brainstem is also involved in integrating input from multiple sensory modalities. And this includes visual, auditory, and somatosensory, with deficits noted in children diagnosed with ASD, such that the auditory and visual integration is disturbed. In addition, children with ASD are less likely to pay attention to either visual or auditory cues from their environment, which has been implicated in some of the motor delays that are noted. So now we return back to the case of Jack, our 4-year-old. The following results are from his neuropsychological evaluation. Jack's intellectual functioning was assessed using the Differential Ability Scale 2nd edition. The scores that we are interested in are the standard scores in the 3rd column from the left. If you look at his abilities, they all fall at least within the average range, suggesting that he is of at least average intelligence. The verbal reasoning measures include knowledge of vocabulary and ability to follow instructions of increasing complexity, both of which were within the average range. Nonverbal reasoning was more variable, with Jack struggling on those tasks that required problem solving, more fluid reasoning abilities. But if you look down to the spatial ability index, superior results are reported. And this includes being able to put puzzles together, things that require the integration of visual and motor information. So there are no real areas of weakness, but there are several areas of strength. Moving on to the next slide. Language testing is an essential component of any neuropsychological evaluation, but is particularly important for kids who are on the spectrum because language deficits play such a large role in the profile. Jack's overall performance on the Clinical Assessment of Speech and Language 2nd edition was average, but it is comprised of a variety of scores. And so we can see that his receptive language index is average, with low average results when it comes to expressive skills. This means that he comprehends what is said to him about as well as other children his age, but his ability to get his thoughts out and express what's going on in his mind is more difficult. Lexical semantic refers to his ability to understand meaning and to give meaning to different types of utterances. And this is average. Syntax is his ability to explicitly tell us how language should be structured, and his understanding and more explicit understanding of the grammatical rules involved in the English language. Adaptive functioning refers to our ability to handle tasks of everyday living, and it looks specifically at what we actually do on a day-to-day as far as dealing with chores, communicating, social interaction, involvement in the general community, as opposed to what we can do. And so a person may be able to do something, but they don't do it, which means adaptive functioning would be lower. And so it's not what you can do, it's what you actually do. As we can see from Jack's profile on the Adaptive Behavior Assessment System 3rd edition, he falls in the average range across all the major domains. And this includes social, which is ability to interact with peers appropriately, practical, dealing with, day-to-day needs in the house and, his own needs, and conceptual, which involves using language, um, math, reading in a way that he can apply it to everyday tasks. Assessment of autism spectrum disorders cannot be complete without looking at behaviors and emotional functioning as they relate to the disorder. In this case, one of the measures that was used was the Behavior Assessment System for Children's Third Edition, which allows parents, teachers, and for older children, self-report measures to assess how they view the person's behaviors relative to others in their peer group, how they handle emotions, how they handle social skills, and how they interact with their environment in general. As you can see in this case, most of the components for Jack's assessment are within the average range. And here we're looking for an average score that's around 50, and most scores that are below 60 are considered within that average range. And so there are a few factors that stand out here. Anxiety. This refers to the amount of tension and concern about his environment that Jack exhibits. We can see that there's a mild elevation here, and so he's likely someone who worries more than is considered necessary, that is less able to handle the demands that are placed on him, and he becomes more frazzled, so to speak. Atypicality is also elevated with a score of 64. And atypicality is a scale that looks at how effectively one is able to fit into the environment and deal with the typical demands placed on someone his or her age. We can see that Jack is really struggling with this. He has a harder time meeting the requirements of the environment, has a harder time, acclimating to the specific situation and doing what is called for. His attention problems are only mildly elevated, but he is still someone who is being reported to be less focused, less able to stay on task, and more easily distracted. All other components in this particular section are average. If we look at the section towards the bottom of the page of the slide, you can see that developmental social disorders is somewhat elevated. And this again has to do with the fact that Jack is less adept at fitting in with his environment, dealing with others in the way that he's expected to for his age. The behavior assessment of executive functioning, as the title indicates, is a measure of executive functioning. Again, can be completed here by parents, can also be completed by teachers, and again, for older children, there's a self-report version. Unlike objective measures such as the CPT-3 or other measures of working memory, etc., here we give the person an opportunity to state how they view functioning. And so again, as with the prior measures, scores in the 60s on up tend to be of greater concern. And so we can see the first line, inhibit, is at a 60. This refers to Jack's ability to experience an emotion but not react to it in an explosive manner, for instance. And so he's someone who is less adept at keeping his emotions in check, and he's more likely to react in a way that is less conducive or less appropriate to the situation. Working memory. This refers to his ability to hold on to information and make use of it so that he can, solve a problem or complete a task. So it's the ability to process and make use of information. And this is something that he struggles with quite a bit. Now, academic skills prove to be an area of noteworthy strength for Jack. And again, we're looking at the fourth column from the left, the one that says standard scores. Here, as with the IQ measures, the standard score that we're looking for is 100 plus or minus 15 points, so 85 to 115, low average to high average. As you can see here, Jack's scores across the board are extremely high. He is well above his age level for all components of this measure, which is in line with his parents have been stating that math, reading, and writing are well developed. Now, the important thing to keep in mind with regard to very high scores such as these, as the demands increase, these scores are likely to dip to some degree. But because Jack is smart and hardworking, and if he gets the right interventions, then he can continue to do as well. So Jack's diagnoses: ADHD and autism spectrum disorder. So with autism spectrum disorder, we confirmed the prior diagnosis, based on his social interaction, communication weaknesses, repetitive motor behaviors, and speech patterns. ADHD is a new diagnosis for him. And the research consistently shows that between 30 and 80% of children with ASD also meet criteria for ADHD. If you recall back to the slides that we showed on anatomy of ASD, they're not all that different from the main anatomical culprits in ADHD. And so these two areas share anatomical overlap, and this explains why there is such a large diagnostic overlap between the two diagnoses. Specifically for Jack, ADHD manifests as a limited attention span, poor emotion regulation, a high level of energy, and a tendency to keep moving around. So recommendations. So many parents and professionals get hung up on one method versus another, ABA versus DIR floor time versus some other cognitive and behavioral approaches. What needs to be made clear is that there isn't that much scientific literature to support using one method over another. What we do know is that there's a consensus regarding what the primary characteristics should be. Now, first, the interventions need to be intense in nature, meaning that it has to be done daily, if not continuously, and for multiple hours per day. And so what is done in school needs to also carry to the home. And this leads us to the second component, which is parent training and support. And so this means that parents must be educated about the needs of their autistic child. Now, many parents come in with a strong knowledge base, others may not. Some of it is socioeconomic, some of it depends on the services that are available in a particular area, or also when the child gets diagnosed. But it is essential that parents are included in the treatment planning and implementation, how to provide advocacy for themselves, and to work with other professionals to make sure that the appropriate services are provided. It's also important to keep in mind that it's not which type of service or intervention should be put in place. It really requires an integration of whatever is needed for this specific child. And so Jack has his specific needs, another boy or girl may have their specific needs, and they may be different from Jack's. And so we're not talking about cookie cutter here. The social and communication domains tend to be the core deficits of ASD and also the most difficult and important to tackle. So since Jack is avoiding interactions in class but seems to relish peer-to-peer interactions at home, it may be necessary to take a different approach in the classroom. And so for Jack, it appears to be that circle time was a difficult component of his day and where he typically presented with unwanted behaviors. So instead of trying to force him to be in that circle, maybe he can sit with the itinerant teacher at some distance from the main circle, but close enough so that he can hear and see what's going on. As he gets used to being closer and closer to the circle, he eventually can start coming in and interacting with his peers more effectively. And so again, we're talking about a behavioral approach that takes into account Jack's needs as well as the needs of the environment, and combining those to create a better approach so that certain goals are achieved. And so the paragraph on the bottom, an effective program should involve the use of carefully planned, individualized instruction that is based on scientific methods. There are many interventions. Few of them have a good scientific foundation, some that do. Parents and providers need to keep up on the literature. There are many people who take advantage of parents, and so we need to make sure that, we avoid as many of these unscientific approaches as possible. And so again, for every specific child, we need to ascertain their specific areas of difficulty beyond whatever criteria we use to get to the diagnosis. And so the diagnoses are based on a set of specifics. But every child manifests and presents differently because each of us is different. And so the interventions, the treatments need to be tailored to the child. One of the most important aspects of an effective program is to help teach the child the skills that he or she needs in a way that generalizes to other areas. And so if you learn to do something at home, how do we make this adaptive behavior apply also to other settings like the school setting, or to some extracurricular activities where the child at some point had difficulties interacting? And so strategies that increase generalization, meaning being able to move from one activity to another and using the skills learned in one place in the new place. This also adds to the ecological validity of an intervention. And the ecological validity means, does the skill that I just taught you help you become more effective in settings other than sitting therapeutically with me? If what I've taught you only works while you're with me, then it's not a particularly effective methodology. And so what I typically recommend is, sometimes it's easier to learn a skill when we're doing it one-to-one. If you look at, for example, martial arts, having a one-to-one teacher, you'll get the skills at a faster rate and more effective, but to actually use those skills, you're better off doing it in a group with peers where you can practice. Same thing for ASD. If you're trying to develop a skill, doing it one-to-one initially allows you to learn the skill with little consequence. Then you apply it in some type of institutional setting, whether it's school-based or classroom teaching, or on the playground with peers. You learn how to apply it, again, in a way that is safe and that gives you the feedback you need in order to be more effective. Speech services are extremely important for children with ASD, and there should be several goals. Conversational skills are quite important for us. It's the way we connect to one another. If we cannot communicate effectively, we cannot develop effective relationships. So it can include things like making sure that you're maintaining the thread of a conversation. And so if we're talking about apples and then you suddenly switch to oranges without taking my needs into consideration, then we've lost the thread of a conversation. It also means taking turns between listening and speaking. So as I'm speaking, you're listening. When I pause, you interject and you're speaking, now I'm listening. And this back and forth allows us to present our perspectives and discuss the issues together. If only one person is speaking, eventually you start fading out, you start losing interest. And with kids who are less forgiving than adults, this makes it difficult to maintain relationships. Beyond the specific language issues and, speaking to one another, there's the pragmatics that are involved. And this includes things such as maintaining personal space, the use of gesture, and the importance of maintaining eye contact. If you start talking to me and, I start looking away, you might start thinking, oh, I'm not interested, so you'll change the conversation. If I get too close to you, you're going to say, hey, this is uncomfortable, and you'll move back. If you look at my gestures and I'm going like this, or, gesticulating like this, you can tell what my emotional valence is. And so it tells you a lot about what's happening without actually having to use words. And so children on the spectrum don't always attend to these as effectively. And so they don't understand when someone is no longer interested in what they're saying. They don't necessarily realize the emotions that the person is experiencing or how they're experiencing whatever the child with ASD is telling them, how it makes them feel. Again, as with changing behaviors, a combination of individual and group services is often best suited to do this, where you learn in the individual sessions how to do a particular skill, in the group session how to perform it in a way that's more realistic yet provides the safety of a therapeutic environment. Children on the spectrum often present with gross and fine motor deficits that require remediation. These can include core weaknesses, stomach muscles, legs, arms, shoulders, back, where they tend to be slouchy, they tend to be more flimsy, and so developing core strength, developing muscle tone, better strength, better balance, and better coordination. And this is important because you can't participate in sports. You have a hard time just carrying your backpack. You tend to be clumsy and bump into things, or you trip over things. You become a slow, uncoordinated runner. And all of these impact how effectively you can interact with others. Occupational therapy is also important for activities of daily living. So some kids with fine motor issues have difficulty dressing themselves, are unable to brush their teeth effectively, have a difficult time using silverware. In school, it can involve penmanship. And so a lot of things get involved, toileting, hygiene, dressing. And so there's a lot that can be done that in many of these, the goals of these therapies is to not just teach a skill, but it's to help the child become increasingly more independent. With regard to medication, there are many reasons for which children on the spectrum are medicated. In Jack's case, he was diagnosed with ADHD, and what ADHD does, it limits your ability to be effective in everything that you do. And so even if you give him the best possible OT or PT, if Jack isn't able to pay attention, then he's not able to benefit. You give him the best math teacher you can possibly find. If he cannot pay attention to what the teacher is saying, then he cannot benefit. And so ADHD has to be dealt with. For a very young child, parents are often hesitant to deal with medication, and that's why speaking to a pediatric neurologist, psychiatrist, or developmental pediatrician is important so that you can learn the pros and cons of medication. Here we're talking about ADHD, but oftentimes there are more aggressive behaviors. There are sleep deficits. And a lot of these can benefit from medication management that reduces the unwanted behaviors and gives more of an opportunity to intervene so that more pro-social behaviors are exhibited. So that brings us to the end of our talk. Thank you for your time. Please provide any comments and subscribe and like my page. Thank you.